in an hour. So thank you very, very much. Thank you for taking the time. And in that light, would it be all right if I answered any questions that you may have following my testimony? It's up to you, Chairman, yeah.
Well, we're going to keep the time equally distributed, so we're just pushing later into the day.
Up to you, of course.
Do you think you have a 5 to 7 minute presentation?
It comes in closer to 8.
Okay, well, Senators, keep in mind what our accomplishment goals are here today.
I'll talk fast, okay? Thank you, everybody, for your time. My name is Dr. Tomlin. I'm a board-certified OBGYN, but following my OBGYN residency and certification, I performed a fellowship in pediatric and adolescent gynecology, and I am double-boarded in obstetrics and gynecology and pediatric gynecology. I am the only fellowship-trained pediatric gynecologist in the state of South Carolina, okay? As such, I see people from across the state. I see people from across all regions, all counties. I see your daughters, believe me, I do. I see all your daughters. I see the daughters of janitorial staff. I see different races, different socioeconomic classes, everything. And as such, I think that I'm uniquely positioned to represent our adolescents and youth and talk about the implications of more restrictive abortion legislation on our adolescents. So to that end, I have 4 major points that I'm hoping to cover today. Firstly, that in South Carolina, we do not provide sufficient education about or access to birth control for adolescents. Second, that once adolescents are pregnant, they're at an increased risk of lifelong adverse health outcomes, as are their children. That the concept of rape and incest in adolescence is much more prevalent than you realize. And that finally, since the South Carolina Heartbeat Bill has come into effect, South Carolina adolescents have already encountered significant barriers to reproductive care. So to my first point, Representative McCravy published this quote 2 weeks ago in the Spartanburg Herald Journal, and you can read it. But my biggest point here is that his opinion is that this bill, or his proposed bill, would end the practice of abortion being used as birth control. But I feel that a statement like this is disingenuous and very limited in its viewpoint. Because for adolescents who go through the South Carolina education system, their sexual education, including knowledge of contraception and birth control, is woefully inadequate. And that's through our legislation. This is actually from the current standard put forth by this body, which says that sexual education for adolescents in schools must stress the importance of abstaining from sexual activity until marriage, and contraceptive information is only to be given in the context of future family planning. If you've met any teenagers, I think you can admit this is probably very optimistic in a viewpoint. So in a recent lecture I gave to my third-year medical students, I serve on the faculty here, I surveyed my class, okay, all of whom had been educated in South Carolina, and I asked them who upon entering college, not even high school, but who upon entering college felt that they had been adequately educated on safe sex and birth control, and 0 people in my room felt prepared. So in my practice, I have found, and this might surprise you, the average age that girls start having sex in South Carolina is 14. 14, okay? So if we're not educating our patients, we're putting them at a disadvantage. So in preparation for my testimony today, I texted a friend whose husband is a local teacher at a local high school here in Richland 1. This was the text exchange. I asked for concrete information that is being given to our high school students about sexual education, and this was the response that I got. I delved deeper. I finally was able to dig this up. This is Richland 1. I've highlighted the things that pertain to sexual health, and this is only for high schoolers now, mind you. But in particular, with regards to contraception, there's this, that there's only to identify the benefits, effectiveness, and risks of pregnancy prevention, but with no further guidance. So in my lecture with the medical students, I asked them, well, if you weren't educated in school, where did you learn about sex? And the overwhelming answer was pornography. And so this is in keeping with recent research that indicates that 25% of American adolescents regard pornography as a helpful source of information about how to have sex. So in other developed nations, such as Austria, Belgium, sexual education in schools begins at an age-appropriate manner, but focuses on physical, cognitive, emotional, and sexual and social aspects of sexuality. So in comparison to our 25%, only 2% of those youth report pornography as their primary source of information. The other problem, though, for adolescents is that access to contraception is extremely difficult in this state. This is probably your health insurance plan. This is the Blue Cross Blue Shield state plan for state employees. And this is from this year. And as you can see, the only contraceptive access to be given for people of this plan are for the subscriber and their spouse, and it is explicit that contraceptives are not to be given for adolescents. So with adolescents on their on a parent's health insurance plan up to the age of 25 potentially, that means your college student going off to college is not covered for health insurance under this plan, the largest in the state, and I come across this barrier every day in my office. So to that quote from Representative McCravey, how can we prevent abortion being used as birth control if we're not educating our youth about birth control in the first place, nor are we giving them access to it? So to enact legislation that's restrictive without first performing a major overhaul of the way we teach our children about sex and also ensuring they have access to contraception is only going to increase the number of adolescent pregnancies in our state. Which brings me to my second point, which is the health risks of adolescent pregnancies. So for this portion, I'd like you to please imagine that your 14-year-old daughter or niece or neighbor or some 14-year-old in your life who you love is pregnant and comes to me as a physician to care for her during her pregnancy. These are the things I'm worried about as a physician. This study was actually published in our preeminent journal earlier this year. And what they did was they used a huge population database to assess adolescent deliveries in the United States over the last 18 years. The first thing I'd like to call your attention to is how many adolescent deliveries there are. That is almost 6.5 million children delivered to children in the United States. That's huge. Secondly, what they found overwhelmingly is that the risks, mental and physical, when compared to deliveries in the 20 to 54-year-old age group, were significantly increased, in particular these, and this achieved statistical significance. This is a statistically significant difference for adolescents having a pregnancy when compared to an adult. Then there are social implications, and I think this study is really landmark and worth a lot of your time. In this study, this group followed women who had been teenage mothers and had the pregnancy and followed them through their lifespan and assessed them again at ages 32 and 42 and looked particularly at social implications of their teenage pregnancy on their life trajectory. And what they found, I don't know if any of you are used to reading medical literature, but you don't see odds ratios like this ever. 7 times more likely at age 32 to have dropped out versus having a college degree. Almost 3 times more likely to be living in poverty. And those effects persisted from 32 to 42. It's not like it was a limited effect, it was persistent. So the implications of a teenage pregnancy for the mother are lifelong. And incidentally, in that study, they also said that these implications did not hold true for fathers of teenage pregnancies. Finally, there are implications for infants who are born to adolescent mothers. This is a study that was published a while ago. We know that there are increased risks of things like preterm birth, low birth weight, but these are also really significant impacts that then follow these children through if they're born to a teenage mother. So in that first study, Stanichenko, they acknowledged that there are some changes happening. They acknowledged that the rate of teen pregnancy in the United States is decreasing, and they attributed it to a combination of adequate sexual education, increased access to contraceptive resources, and increased use of contraception. So frankly, for us to prevent pediatric and adolescent abortion, we need to prevent pediatric and adolescent pregnancy. And so the way we do that is by overhauling our sexual education in schools, increasing access to sexual health resources, and increasing access to contraception across the state. Which brings me to my third point, which is that listening to these debates, I hear people very glibly refer to the concept of rape and incest, and I can tell you, I see someone who, in my practice, I see someone in my practice every day who has suffered through sexual assault, every day. Last year, I saw 3 children in the course of 3 weeks, ages 11, 12, and 14, all of whom had been raped, and 2 of whom were pregnant. And so I'd like to very quickly share their stories with you, and for their protection, I have not used their actual photos, but representative photos. My first patient was an 11-year-old. Her name was Maricela. She was raped multiple times by her uncle, finally removed from her home when her pregnancy was discovered. And the pastor of her local church and his wife took her in to foster her. The foster mother came to me and said that she had always self-described as pro-life, but she couldn't stand by and not support the termination of this child because watching this 10-year-old have morning sickness in her house every day was destroying her, and that her children didn't understand why Maricela was so sick. The child weighed 90 pounds, y'all, 90 pounds. This was putting her life in danger. Ultimately, Maricela went on to have a termination. And I talked to her guardian last week. She started middle school yesterday. She's really happy. She's healthy. She's thriving. She's not a mother. And I think that that's important. Literally, the 2 days after Maricela's termination, I met Sunny. Sunny had been repeatedly raped by her mother's 44-year-old boyfriend. And that family decided they chose to carry that pregnancy to term, which was their choice. And that's fine. She was taken out of school early in her second trimester because, in the words of her principal, it was very upsetting to have a pregnant girl in the elementary school. So they took her out of school and they forced her to be homeschooled. She ultimately went on to develop preeclampsia. She had an induction of labor. She had a vacuum-assisted vaginal delivery, a postpartum hemorrhage. She ended up needing a blood transfusion, and then ended up with postpartum depression that was so severe, she's been started on antidepressants and almost had to be hospitalized. And the family isn't sure if she's ready to go back to school. So she's, we think, still just at home, this 12-year-old. So that's 3 weeks of my life. That's 3 weeks of my life. So this is not a glib, easy thing, okay? Last week in my office, I met Madeline. Madeline is 16, and she presented for the insertion of a long-acting contraceptive device in her arm because she was worried that that access is going to be limited by the conversations that we're having. She was currently using a contraceptive patch as her birth control method, except on a routine pregnancy test, she was positive. So my team had to tell her and her mother, who was with her, that she was pregnant. And they sat there in my office sobbing, tears running down their face, saying, what are we supposed to do? What are we supposed to do? And I had a team member with me and one of my young resident physicians, very staunchly pro-life, and she walked out in tears. It was the first time she had ever reconciled what she believes and looked in the eyes of someone and seen the implications of what that meant. And it really shook her. It really shook her. And so they were devastated. They didn't know what to do. They asked me if they could travel. She was 10 weeks, so already too far along in South Carolina for me to offer her a termination. And they disappeared. I haven't seen them. I don't know what they've decided to do. And I'm really frightened because this is happening. This is a text that I got from a friend of a friend 1 week to the day after Dobbs was overthrown. This is an unfathomable loss of life. This is frightening, and I'm scared for my patient, Madeline, because I don't want her to be this patient. So when you hear that phrase, again, a phrase that can often be used glibly, banning abortion doesn't stop abortion, it just stops safe abortion. When you hear that, that's what this looks like. That's what this looks like. Since Dobbs was overthrown, these are some of the messages I've been getting. These are real messages from my nurse to me, telling me about my patients and how scared they are and their families are. So regardless of intent, this body has created a maelstrom of fear, anxiety, and worry that is not being abated in the community. And I really beg that it is carefully considered before we attempt to enact any legislation on abortion. Because before we can enact any limitations on abortion, I ask you to please consider how we're educating our South Carolina youth and how we can educate them on safe sex practices and reliable pregnancy prevention in a non-judgmental and factually accurate manner. How we can increase South Carolina youth to healthcare providers, sexual health resources, and contraception regardless of where they live. Children in rural communities need that same access to the children in Columbia who get to see me. Pregnancy in adolescence has lifelong implications for social, mental, and physical health of the mother and any infant that they may carry. Passing legislation that limits access to abortion, but also limits my ability to talk to my patients about abortion is not making them safer, it makes them more scared and more desperate. I'm proposing that I, as a physician, knowing the risks to my patient, would be jailed or have my medical license revoked for telling them about that is really draconian. And to end, this text, I'm gonna leave you with this. This text scared me. This text upset me. This is a child whose life was lost. She died in her bathroom, bleeding to death, scared and afraid. Scared and afraid. And she thought that we as a state valued the life of her fetus more than we valued her life. And I am confident that if you could ask her parents whatever they believe about abortion, if they could have procured an abortion for this child and brought their daughter back, I bet you they would have. I bet you they would have. So in summary, I have my testimony and I have all of my references available for you, but I will also be submitting the joint statement, which is endorsed by the premier international body on pediatric and adolescent gynecology, which also echoes many of the sentiments that I brought forth for you today. And thank you so much for being accommodating with my international flight.
Thank you, Dr. Tomlin. Senator from Richland, Senator Scott has a question.
Just one quick question.
Yes, sir.
What age would you recommend we begin to educate these young people about sex?
Yeah, that's a
sex
great
education?
question. So I think that looking to the example of other developed countries, I think that there's a lot of fear that by introducing sex education at a young age, we're somehow condoning or encouraging sexual exploration. And I think that taking that multifaceted approach that we see in other countries where they're doing age-appropriate understandings of things like safe relationships and knowing body boundaries and things like that is going to be really important. But again, this idea that, I mean, I'm not kidding, 14, the average age of girls I see in my office having sex is 14. Those are 8th graders. So unless we're catching these kids earlier and finding a way to integrate, I think we're missing a boat here. And so having that more full spectrum care where we're analyzing, social implications, things like that.
So then maybe somewhere around 4th or 5th grade beginning?
So I think that that conversation can be introduced in a healthy way earlier, right? So I also am a mother. I have 2 young daughters, ages 9 and 6, and my daughters know where babies come from. That's my choice as a parent, and I will say that when I educated my girls on where babies come from, I said, not everybody's mommies and daddies are going to tell them this right now, but they were able to have a pretty basic understanding, and they were able to understand that there's medicine that you can use that can help you plan when you want your pregnancy to come. So.
Senator from Greenville, Senator Loftus.
Thank you, Mr. Chairman, and I don't have a question. Well, I guess I do. But
I hope you have a question, Senator.
well,
It's gotta be a question.
it will be a question. Are you aware that the fact that there is opportunity for, and I don't know whether you agree with it or not, abstinence-based sex education? There's money for that. And then when I was in the House, did you know that for 10 years or more has been a fight not to prevent that from being presented in our schools?
Well, currently that's the standard, is abstinence-only education. And so that, I mean no disrespect when I say this, truly I don't. However, to assume that abstinence-only sexual education is going to protect all of our youth is naive.
If I'm not naive,